learn every day, every single moment. So thank you to be here and join us. I'm going to, for my presentation, I will chair alone, so be patient with me. Okay, so the topic is how to cross lesion, and we will do with a case-based presentation. So there is a recorded case in my lab, and we will discuss about the opportunity and the possibility to cross lesion with a system based on microcatheter or support catheter, whatever you want to name it, or directly a balloon and the wire. And of course, after we treat the lesion, the opportunity and the needs, when, why, and if it's always a good choice, a good opportunity for the patient to receive a treatment with drug-coated balloon. So this is my disclosure, and this is the case. A 79 years old gentleman, of course with diabetes, neurovasculopathy, hypertension, and ischemic cardiopathy. A loop recorder holder and a mechanical aortic valve. We have leukemia, chronic lymphoid. The Wi-Fi classification of the lesion is 331, and the TCPO2 is 7 millimeters Hg. You can see the lesion all around the ankle, and there is an extension of the lesion towards the heel in the calcaneal area. So let's go to the case, and of course here I have come on out. Okay, CO2 angio. As you know, we use CO2 for all the patient, and we try to integrate whenever is possible with some small amount of contrast medium, especially to perform the 2G perfusion angio in the beginning and in the end of the procedure. As you could see, we have a severe and long occlusion of tibial anterior and posterior, and the flow in the foot was very bad. We decided to arrive into the foot. You can see that a tarsal artery, and in this case we have to remember anatomical, if I succeed in stop just for a moment the video. Okay. I want to remember you that 13% of patients, they have an hypoplastic dorsalis pedis. So the flow, the major flow to the forefoot is through the tarsal artery, and you can see how big is this artery. Don't try to recanalize dorsalis pedis because it's hypoplastic, not diseased. You can achieve a perforation, of course, in that case. So this is the anteroposterior view, and you could see we decided to use for the navigation the Surgeon 1.4, and we, after the pre-dilatation, we decided to treat the anterior tibial artery with a long balloon, 3 millimeter Luminor 1.4. Again, with the system 1.4 as the microcatheter 1.4 together with the wire. This is a Terumo Advantage 14 wire together with the surgeon catheter. You can see here the progression of the system in the middle of the calcification. This vessel is calcificated all around, so there is concentric calcification and eccentric calcification. There is a mixture of calcium. In this case, I decided to shift from the intraluminal progression of the wire into the subintimal progression. You can see we are using the stiffer part of the wire immediately behind the radiopaque tip of the wire. The wire is manipulated with the rotation. When we have the loop, in order to maintain the loop as small as possible, we rotate, we drill the wire with the loop. In this way, we help the wire to maintain a very small loop. The progression in the subintimal space, you can see here, it's not easy despite the aggressivity of this part of the wire and despite of the high support of the microcatheter. Despite it's a 1/4 microcatheter, the support is really excellent. We can use this system until we succeed to perform the dissection. When we cannot perform a dissection and we are very close to the re-enter area, we have to decide to shift to use the tip. Here you could see the re-enter moment of the wire with the tip into the distal lateral plantar artery. Now the wire is going into the arch, and we can arrive directly into the first toe. This is the digital or metatarsal artery of the first from the posterior circulation, so in the plantar side of the foot. You can see how calcified is the correspondent anterior digital arteries from anterior circulation from the dorsal side of the foot. So whenever we arrive with the support catheter very, very close to the arch, sometimes it's possible to check with a small amount of contrast medium the outflow. This is a very, very important phase, because if we have outflow, if we have a nice distribution of the blood flow in the forefoot, the outcome, the clinical outcome of the patient will be for sure better. And so remember the classification, the Roberto Ferraresi classification, when we are speaking about the SAD patient, we have to remember to classify the grade of calcification too. So MAC 1, 2, or 3. Especially when we have SAD patients with the MAC 3 calcification, the outcome could be very, very poor, despite a good acute result like this. We have to expect an early reocclusion and a very bad clinical behavior with the patient. So this is the 2D perfusion, the final 2D perfusion that show us, you can see here, these two curves, how different they are, and there are some artifacts from movement, but anyway, you can see the contrast medium can arrive very early in the foot, and the density of the contrast medium in the forefoot, especially, this is a blushing effect that could suggest us the efficacy of our procedure. Well, after this procedure, and we can discuss why we used directly in this case drug-coated balloons, because the complexity of the wounds, because when we have this kind of severe wounds, huge wounds, we have to try to maintain the patency as longer as possible. And this is the follow-up of the patient. You can see here the progression of the wound healing process. You could see now better the extension of the wounds towards the heel and the calcaneal area. The first two pictures after 8 months and the last picture after 1 year. This patient was included and enrolled in the Biblios study. I told you yesterday about the Biblios studies, which is a study from Belgium centers and Italian center. We enrolled a huge amount of patients with CLI, exclusively with CLI. Root 4-5 is the minimum, so very interesting study, and the result will be very, very interesting. So, in conclusion, when intraluminally crossed, so no contraindication in below the knee for drug-coated balloon in our experience. And of course, the use of sample catheter could be expensive compared the use of a balloon and a wire together, but probably much more efficient. If you have questions, please. We have to try to discuss and to solve